club foot is a congenital malformation of one or both feet. The term congenital means existing at birth. Causes are poorly understood, but two hypotheses are often put forward. The first being that of poor positioning of the baby's foot during intrauterine life, and the second being heredity. The risk of having a child with a club foot is greater if there is already a case in the family. Occurrence is about 1 to 2 cases per 1,000 births, with the number of boys being twice that of girls. In 50% of cases, club foot is bilateral. Most of the time, the foot is deformed in varus. The heel bone is turned inwards. Adduction, the foot axis deviates inwards. Inversion, the foot twists inwards. Equinus, the foot is in a pointed position. For this reason, the foot is termed an Equine-Varus clubfoot. In addition to these abnormal positions, movement of the foot is limited. Movement is reduced by bone contact with the talus bone and muscular contracture. The skin is also creased on the inside of the foot and ankle. Associated with the club foot, there is a risk of hip dislocation and leg torsion. There may also be malformation of the hands, called club hands, but this is rare. The severity of the club foot does not depend on how deformed the foot is, but on the degree of correction possible. In other words, how stiff the foot is. Type 1. This foot is easily corrected and is termed supple. Type 2. This foot presents greater difficulty for correction and is termed stiff. Type 3. This foot is almost impossible to correct and is termed irreducible or very stiff. The type of clubfoot may alter, becoming more supple with treatment and developing from type 2 to type 1, for example. Without treatment, the foot becomes stiffer, changing from type 1 to 3. The talus forms an articulation with the peroneal tibia and the fibula and is held between the malleoli. This is where plantar and dorsal flexion mainly occur. The calcaneum is one of the important pivoting points. It articulates with the talus above and tarsal bones in front. This set of bones constitutes a sort of double articulation which allows the foot to adjust to the ground surface. This severe case illustrates the talus displaced outside the intermalleolar space, becoming a mechanical obstacle which positions the foot in equinus. The calcaneum is in plantar flexion, provoking equinus in all the tarsal and metatarsal bones. The calcaneum is in varus, provoking adduction of all tarsal and metatarsal bones. Equinus and adduction of the front of the foot result in inversion. The muscles and tendons become adapted to this deformation and maintain it with contracture of the plantar flexors and inverters and stretching of the everters. Deformation can be corrected satisfactorily by means of physical treatment. However, to be efficient, this should start very early on. The principles of physical therapy are, firstly, correction of the foot using techniques of massage and passive mobilization. Secondly, maintaining this correction to give the structures of the foot time to adapt. Here we use techniques of muscular stimulation and immobilization. Thirdly, follow-up of the child based on functional rehabilitation and regular assessments in order to avoid any relapse. The family is involved and trained in each step of rehabilitation. This is essential for the success of the treatment. In cases of an irreducible clubfoot, surgery may be useful. This is always a last resort, as surgery is very expensive and may lead to complications. Physical therapy should always be attempted before considering surgery. In the case of irreducible fixed club feet, untreated older children or adults, treatment proposed consists of shoes for comfort. Any other action risks aggravation. Start the treatment as soon as possible. A baby's bones are soft, small, and are not completely formed. The foot is therefore malleable, and treatment is much easier, giving better results. Work in a calm atmosphere. The child must be relaxed when receiving treatment and could, for example, be given a drink before the session. Explain what you're going to do. You must reassure the mother, and it is essential that she be involved in treatment. Be gentle. Never use force. Too great a pressure on the bones of a baby may damage or destroy them. Don't forget that your hands are enormous in comparison with the tiny foot.
What is a clubfoot? A clubfoot is a congenital malformation of one or both feet. The resulting deformation most frequently consists of Equine-Varus, adduction of the forefoot, inversion. The clubfoot can be classified in 3 types according to how reducible it is. Supple. Type 2, stiff. Type 3, very stiff or irreducible. What can be done? A clubfoot must be treated as early as possible after birth, using physical therapy based on 3 principles. First, correction of the malformation by massages and passive mobilization. Second, maintaining correction by stimulation and immobilization. Third, regular, long-term patient follow-up. It is essential that the family be involved in each stage. Occasionally, surgery may be necessary, but only as a last resort. For adults who have never had any treatment, providing shoes for comfort is the only useful manner of treatment. The fundamental rules of physical treatment are to treat as early as possible, to work in a calm atmosphere, to explain and involve, to be gentle.
it is very important to respect certain major principles in the treatment of the club foot. You must start the treatment as early as possible, work in a calm atmosphere, explain what you're going to do, and be gentle. There are 3 types of treatment. First and foremost is physical therapy, an efficient but lengthy treatment based on 3 principles. The first principle is to correct deformation by means of massage and stretching and passive mobilization. The second principle is to maintain this correction by means of muscular stimulation and immobilization using strapping, plaster, splints, or shoes. The third principle is to follow up the child. This is essential and involves functional exercises and regular assessments. The second type of treatment, when physical therapy is not sufficient, is surgery. Finally, for adults with feet that have never been treated, palliative treatment in the form of comfortable shoes can be proposed. Gentle massage is followed by stretching of the retracted tissues. Massage has 3 main objectives: to increase the baby's confidence, to achieve a little muscle stretching, and to avoid skin shrinkage and make retractions more supple. Massage and stretching are applied to the toes, foot, and leg. They are also applied to the posterior upper region of the heel and the interior of both the ankle and the foot. 10 to 20 minutes of massage should be carried out 2 to 3 times per day. In correcting a club foot, respecting the following principles is essential. The knee must be bent to relax the Achilles tendon. The fingers must be precisely placed. The orderly movements must be followed. Firstly, correct the back of the foot. Secondly, correct the front of the foot. Thirdly, reduce equinus. If dorsal flexion is applied too soon, there is a risk of crushing the talus and severely damaging the foot. To mobilize the left foot, place your left hand behind the bent knee and your right hand on the ankle, with your index finger on the heel and your thumb at the level of the talus. If you change the foot, reverse the position of the hands. Keep the knee bent to relax the triceps surae and therefore get improved correction in dorsal flexion. Mobilization is carried out in 6 steps. First step, pull on the calcaneum in the axis of the leg in order to free it. This traction is applied using the index finger, which hooks on the calcaneum. Second step, gently push the talus into its correct position with the thumb. Don't push too hard, or you may damage the talus. Third step, correct the varus of the calcaneum. With the tip of the index finger, try to bring the calcaneum towards the exterior. Fourth step, the hand which was behind the knee comes to hold the front of the foot flat. Apply traction in the axis of the foot to make space between the foot bones. Fifth step, with the same hand continuing traction, correct adduction and inversion in the front of the foot.
Caution. When the talus is in place and inversion are corrected, and only at this stage, Carry out the sixth step.
Sixth step. Correct equinus. Both hands are working at the same time. Whilst maintaining the flexion already acquired, they gently bend the ankle dorsally. Keep this position for several moments and then start again. To summarize mobilization: 1. Pull on the calcaneum. 2. Push on the talus. 3. Correct the varus of the calcaneum. 4. With the other hand, pull on the front of the foot. 5. Correct the inversion and adduction of the front of the foot. 6. Apply and maintain dorsal flexion to the ankle. After several sessions, you can work with the knee extended while maintaining a corrected foot position at a 90-degree angle to the leg. Mobilization should be applied for 20 minutes, 2 to 3 times per day. The participation of members of the family is very important. Remember to involve the mother and father. Explain clearly why treatment is necessary. After massage and mobilization, it is very important to maintain correction to allow the foot structures to adapt to this new position. Muscular stimulation is carried out after each massage and mobilization session. They are aimed at improving the action of the dorsal flexor muscles and the foot evertor muscle. Movement should be stimulated by touching the external part of the foot and the leg with your nail or a toothbrush. You need to feel around in order to find the right zones of stimulation. There are positions that make this easier, such as external rotation of the hip and blockage of the foot in slight valgus. It is very important to encourage members of the family to take part. They must be taught how to do the stimulation themselves. The goal of immobilization is to maintain the correction acquired, and this must not be damaging in any way. Immobilization does not correct, but maintains. The type of immobilization used depends on the type of club foot, the age of the child, and materials available, as well as the family's possibilities. For a supple, reducible foot of type 1 or 2, strapping is used. For an older child or a rather stiff foot of type 2 or 3, plaster is used over strapping. When the foot is corrected, or in countries where plaster is not used, a splint can be used. When the child is standing up and the foot is supple, you can move on to shoes. Remember to involve a member of the family during immobilization. Explain his or her role and make sure that this is understood. The strapping technique uses an adhesive, non-stretch bandage, such as sparadrap, and a sole. The strapping is applied just after the session of massage and stimulation. 2 people are needed, one to hold the foot in the best possible corrected position, and the other to apply the already cut adhesive bands. To apply strapping, you must first prepare the skin by swabbing with benzoin lotion or applying gauze. Then position the first band on the heel to maintain the correction of the calcaneum. Then position the foot on the sole, placing one band behind the toes, one on the neck of the foot, and one behind the heel. Now position the 2 leg bands. These 2 bands should be secured on top of the foot, passed under the foot, brought up the outer side of the leg, encircling the knee, brought down the inner side of the leg. 2 circular bands secure the bandages at ankle and calf level. The second band is more oblique than the first and crosses over it to correct the front of the foot. During the initial sessions, apply a strapping under the knee to correct the forefoot. Do not pay too much attention to dorsal flexion. Strapping is usually stopped when eversion and dorsal flexion become possible. To summarize, strapping is carried out in 4 stages. Firstly, prepare the skin, then secure the band on the heel, position the foot on the sole, and lastly, position the leg bands.
Caution. Only apply plaster if you are able to follow. It should never be corrected once the plaster has been applied.
Plaster can cause injuries or force joints. In order to avoid this, apply the plaster over strapping. After strapping and before applying the plaster, you must pad with cotton, especially around the malleoli, on the outer side of the knee and the heel. Then, unroll the plaster bands without squeezing them. Leave the toes uncovered for supervision. Wait for at least 2 hours for the plaster to dry before allowing the child to leave, to be sure that the plaster is not too tight and hurting the child. This type of plaster should be changed once or twice a week. Between each plaster application, treatment to correct the deformation should be given. This technique needs a trained team, access to the child, and, above all, parents who understand the importance of supervision and punctuality. Plaster is usually stopped when eversion and dorsal flexion become possible and the talus remains in the correct position. To summarize, plaster is applied in 4 stages. 1. Application of strapping. 2. Protection of high-risk regions. 3. Application of plaster. 4. Precise checking. Splints are made of steel, aluminium, or PVC. They are a good means of immobilization because they are easy to make using cheap materials. They are also easy for the mother to fit. 2 types of splints can be seen. First, knee holding. This is used when you want to loosen the triceps surae to improve dorsal flexion of the ankle. Second, knee free. This is used when you want to free the knee to stretch the triceps and increase dorsal flexion whilst holding the foot corrected at a 90-degree angle. To fit the splint, firstly secure the foot from front to back, then the leg, and lastly the thigh. Eversion and equinus of the sole are corrected in relation to the child's progress. Use of the splint is stopped when the foot remains in a satisfactory position when the child is relaxed. You can continue to use splints at night when the child is wearing shoes during the day. Shoes are used to maintain the child's feet in a corrected position whilst allowing him to learn to walk. Rules for making the external part of the sole is wider to force the foot flat when weight bearing. The inner side is straight. There is no heel to avoid equinus. There is a strap to maintain the ankle, and the shoes are open to facilitate good positioning. Shoes are no longer used when the child has a correct position at rest, a satisfactory gait, and no longer deforms shoes. This may take several years.
There are 4 types of immobilization. Strapping, used for types 1 and 2. Plaster, applied over strapping for type 3 or bigger children. Splints for types 1 and 2 towards the end of treatment or in countries where plaster is not used. Shoes used as soon as the child stands up and correction is satisfactory. Caution. Supervise the development. Relapses occur frequently.
In order to avoid this, you must carry out functional treatment and assessments. Do exercises in game form to prevent or limit relapse by maintaining a high degree of joint movement. These exercises should strengthen the muscles and be adapted to the child's context. Here are some examples: the balance board, the tricycle, the mini trampoline, walking like a duck or using small wooden boards. The child must come to the center regularly so that you can check his feet, suppleness, muscle strength, shoes, and the exercises done by his parents. Visits should be every month or two, at the beginning, every 6 months when the child is bigger. This supervision should continue until the child has finished growing. It is important to teach the family how to do the exercises, watch for development, and to come for the assessments.
Caution. Surgical technique. Follow-up is often impossible.
However, in certain cases of very stiff club feet, surgery can be resorted to. The aim of surgery is to elongate tendons. An arthrodesis may be carried out for an older child or adult. Surgery must be followed by a period of immobilization and intensive physical therapy, or results will be poor. It is often expensive and even ruinous for the family. This must therefore be taken into account in taking the decision. Physical therapy must always be attempted before deciding to send a child for surgery. Occasionally, teenagers or adults who have never been treated come to the center. In these cases, the deformation is irremediably rigid. The treatment you can propose is simply a treatment for comfort, namely a pair of special shoes, distributing weight and avoiding injury to a maximum.
To summarize, remember that the treatment of club feet must respect the following principles. Treatment as early as possible. Working in a calm atmosphere. Explaining what you're going to do. Being gentle. There are 3 types of treatment. First, physical therapy. This is carried out in 3 stages. The correction of deformation by means of massage with stretching and mobilization. This is carried out in a very precise order. Maintenance of correction by muscular stimulation and immobilization. There are 4 types of immobilization: strapping, plaster, splint, shoes. Supervision of the child. This includes two essential points: functional treatment, adapted to the context of the child, and regular assessments until adolescence to avoid any recurrence of the deformation. Throughout the entire treatment and at each stage, the family must be involved in exercises and therapeutic progress. This condition is important for the success of the treatment. Surgery. This is used only as a last resort. Palliative treatment. Shoes for comfort can be provided for adults who have never had treatment.
In the treatment of children with club feet, techniques of immobilization play a primordial role. Their aim is to maintain correction acquired by physical therapy. They should never apply force to the foot or exceed manually acquired correction.
Caution. Immobilization never corrects.
The four types of immobilization used most frequently are strapping, plaster, splints, and shoes. The type of immobilization will depend on the type of club foot, the child's age, materials available, the family's possibilities, and, of course, the child's development. For a supple and reducible foot, types 1 and 2, in a baby, strapping is used. In a bigger child who may damage the strapping, or a baby with a rather stiff club foot, types 2 and 3, plaster is applied over the strapping. When the foot is not as stiff and the talus is not dislocated, types 1 and 2, or in countries where plaster is not available, a splint is used. When the child is old enough to stand up and the foot is more supple, shoes may be used. Continuing to use the splint at night is often necessary. Strapping is an immobilization technique using non-elasticated adhesive bandage and a sole. The advantages of this technique are that it's relatively inexpensive, it's generally quite easy to find, it carries no great risk, it adjusts perfectly to the foot's position and therefore to progress made, and it's easy to take off for daily exercise. Inconveniences are that strapping is not very strong and will not withstand the child's movements for long. The quality of some bandages occasionally causes irritation or an allergic reaction, and 2 people are needed to apply the strapping, and there is a certain amount of preparation. To apply strapping, you need a tape measure, a pencil and paper, a pair of scissors, gauze or benzoin lotion, a sole the size of the foot, and adhesive bandage rolls of the right width. It is important to use a sole adapted to the child's foot. In order to keep the front of the foot in a corrected position, the inner border of the sole should be straight. To take measurements, put the child's foot on a sheet of paper and draw the outline. Then trace a straight line from the heel towards the toes. In order to respect the width of the foot, note the width exceeding the line on the other side. Retrace an outline, cut and make the sole following the model. The material used should be smooth, such as plaster, wood, leather or plastic, in order not to injure the skin. When applying strapping, the child should be held firmly in the corrected position, as he may move. To apply strapping satisfactorily, you must be quick, so cut the bandages into length first. Measure the length of the various bands on the child with the tape measure in the same order as that in which you will apply them. Don't forget to take the thickness of the sole into account. Cut the bandages according to the measurements taken, then place them in that order on the edge of the table. During this time, the child is quietly held in his mother's arms. The strapping is applied just after the session of exercises. 2 people are needed once everything has been prepared. One holds the foot in position achieved during the exercises, while the other applies the strapping. Before application, protect the skin by swabbing with benzoin lotion or by covering with gauze, fixed with adhesive strips both at thigh and toe level. Place a circular band around the calf. This will serve to attach the heel band, which goes down the inner side of the leg, under the heel, with varus corrected, and up the outer side of the leg. It is secured with 2 open circular bands at calf and ankle level. Then position the foot on the sole by means of a band behind the toes, a band around the neck of the foot, and an oblique band going from the inner underside of the foot up behind the calcaneum and down to finish under the sole. Then position the first leg band, which holds the foot in eversion. This is secured on the top of the foot, going towards its inner side. It then goes under the sole and up the outer side of the leg. At this moment, you should have maximum correction of the foot and the band should be held taut. The band goes round the knee and then goes down the inside of the leg. At this point, do not tauten the band but secure it to the leg. Any traction could result in pulling on the skin and causing injury. Fix the band with 2 open circular bands on the leg at calf and ankle level. The second person holds the foot in the corrected position without moving. The second band will hold the foot in eversion and dorsal flexion. It is secured on the top of the foot at the level of the first metatarsus. It goes under the foot obliquely, crossing over the first band and therefore behind it. The band should be held taut. It then goes round the knee at a 90-degree angle. It goes down the inner side of the leg. Do not tauten the band but secure it to the leg. 2 circular open bands then secure the band at calf and ankle level. These circular bands are not closed in order not to block circulation of the blood.
Strapping should be prepared in advance so that it can be applied rapidly. One person holds the leg and foot in the corrected position without moving. To apply strapping, you must protect the skin, block the heel, position the sole, Position the two leg bands by securing them with two circular bands.
The plaster is an immobilization technique which uses plaster bandages. When wet, these become soft and can easily be applied, respecting the shape of the limb. When it dries, the plaster hardens, becoming rigid, and therefore immobilizes the limb. Advantages of plaster are its widespread availability, its degree of rigidity and solidity, which ensures immobilization and resistance to the child's movements. Plaster can be left on for several days. Inconveniences of plaster are the technique of application, which needs great care and must be satisfactorily mastered, the danger of incorrect plaster application or dampening of the plaster by water, urine, or sweat, which can cause severe injury. The need for close supervision by the team and especially by the family. To apply a plaster, you need cotton wool to protect the leg, plaster bandages, and warm water.
Caution. Correcting the position of the foot whilst applying the plaster.
To avoid this, you must first apply strapping to hold the leg and foot in the corrected position. The limb will subsequently be held rigid by the plaster. The leg and foot must be protected to avoid injury. Put cotton wool around the leg, especially around the at-risk areas, the malleoli, the outer side of the knee, the heel, the head of the fibula. For the application of the plaster, a helper holds the child's leg. He does not correct.
Caution. You must not.
To apply a plaster, you must wet the bands for a few seconds and then unroll them on the leg without pulling, as any traction on the skin can cause pressure and injury. Smooth the plaster without tightening, using a gentle, regular stroking movement. Avoid any pressure. Leave the toes free in order to be able to check the plaster when it's dry. Once the plaster is finished, leave it to dry without any pressure or restraint. Wait for at least 2 hours, and then check the toes. They should all be normally colored and warm and able to move. Check the plaster. It should not be tight or press anywhere on the limb. Check the child. He often goes to sleep after plaster application. If he's still crying an hour after this, it's abnormal.
Caution. Never let a child leave. To summarize, 2 people are needed. One holds the child while the other applies the plaster. To apply a plaster cast, you need to apply strapping to protect the leg and the foot, to apply the plaster, to leave it to dry for 2 hours and then check it.
The splint is an immobilization technique which uses a relatively rigid material, plastic, aluminium, which is adapted to the shape of the child's foot. Advantages of the splint are, it's very easy to put on and take off, even by the family. This allows them to do exercises to correct the deformation. It's light and easy to clean. Inconveniences are, it's not as easily adaptable to the child's progress, the time to manufacture it may be long, the iron may injure the talus or the skin. To make a splint, you need paper and pencil for measurements, tools and materials necessary to make the splint, crepe or adhesive bandages to secure it. Two types of splint can be seen. First, the knee-holding type. This consists of a sole with a straight inner border, an external leg bar, and a crural bar at a 90-degree angle to the leg one, which comes just under the grated trochanter. This immobilizes the flexed knee in order to loosen the triceps and get improved correction of the ankle. Second, the knee-free type. This consists of a sole with a straight inner border and an external leg bar. This is used when you want to free the knee to stretch the triceps, particularly at the end of treatment. First and foremost, the foot must be placed in the splint in as corrected a position as possible. Secure the foot with a crepe bandage. Position the leg bar and wind the rest of the bandage round the leg and splint. This technique is very simple and can easily be taught to the mother.
The splint is a very simple technique. There are two types, knee-holding and knee-free. The splint is held in place with a crepe or adhesive bandage, starting at the foot and going up the leg.
The shoe is an immobilization technique which allows walking whilst keeping the foot in a satisfactory position. Advantages are that they are made to measure and are therefore well adjusted to the child, and they allow the child to walk and therefore help him to become socially integrated. Inconveniences are that the leather can become misshapen in the long term. This is usually more expensive than the other techniques. Manufacture necessitates good knowledge. The characteristics of these shoes are the following. They are open, allowing a satisfactory foot position. The inner border is straight, avoiding adduction in the front of the foot. The outer part of the sole is wider than the shoe. This forces the foot, when weight-bearing, to be flat. They are high, giving the ankle good support. There is no heel, avoiding equinus recurring, except in the case of knee recurvatum. The leather is thicker in the outer part to avoid the shoe becoming deformed too quickly and losing its action of support. Leather straps can be added to keep the ankle in a good position. The shoe must be completely open to place the foot in the corrected position. It is then laced or closed, tightening to give adequate support. It is essential that the parents know how to fit the shoes without hurting the child. It is then very important to watch and supervise the child learning to walk. He will often be frightened after all the treatment he has already had. He may need an aid, such as a walker, to gain confidence.
Shoes are used at the end of treatment when correction is satisfactory and the child can stand up. Shoes are open and high, with a straight inner side and a wide outer section of the sole. a thick leather outer part and a leather strap. There is no heel. Learning to walk should be supervised and guided. To summarize, remember that there are 4 types of immobilization frequently used in the treatment of children with a club foot. Strapping, plaster, splints, shoes. These immobilization techniques are only used to maintain the correction acquired by mobilization and massage. The choice of technique appropriate to the child depends on the type of club foot, the child's age, the materials available, the family's possibilities, and of course on the child's development. In general, we use strapping for types 1 and 2, plaster for types 2 and 3, splints for types 1 and 2, shoes for type 1 for walking. All these techniques require close supervision and follow-up of the child.